in South Africa. And he then completed internal medicine training as well as fellowship in nephrology at the University of Toronto. He also received an MBA from the University of Washington. Dr. Shankland, as an educator, he has received numerous teaching awards as a resident fellow and faculty, and was also the program director for the nephrology fellowship at the University of Washington. He's an NIH-funded leader in glomerular basic research and has authored more than 150 peer-reviewed publications. Please join me in welcoming Dr. Stuart Shankland.
Thanks a lot. Well, thank you for that nice introduction. I'd like to thank Dr. Weiss, Dr. Hare, Dr. Fononi for inviting me here today. And I'd like to, in particular, thank the Lipson family. I just met Mrs. Lipson a second ago, and there she is, and who had the foresight, as I'm reading here, that the family's wishes that the donations in his memory be made to the Arthur E. Lipson Featured Speaker Endowment at the Interdisciplinary Stem Cell Institute at the University of Miami. So thank you for giving the patients with similar conditions hope, and thanks for giving researchers hope and the opportunity to interact so we can improve the lives of the people that we all care about. So thank you very much for that. As this is medical grand rounds, I thought I'd start with a case. And this is a 34-year-old African-American male who complains of swollen ankles and frothy urine. There will be an exam for the house staff. Review of systems, some recent fatigue, loss of appetite. Past medical history, he was told that he had quite a touch of proteinuria way back when he had a medical done. Mother's hypertensive. And the relevant findings of the exam is he's hypertensive, he has some leg edema, and occasional scattered crackles at his bases. The pertinent lab are that his BUN's elevated, his creatinine's elevated, he has a low serum albumin, his cholesterol's elevated, his crits on the low side, and the LFTs are normal. And when we look at the urine, there were no cells under the microscope. He had an elevated albumin to creatinine ratio of 6.2. Everybody got the case? A kidney biopsy was ultimately done. But what I'd like to do in the next 40 minutes or so is try and review these three questions around our patient. Number one is, why would you, as a non-nephrologist but an important healthcare provider, be concerned about his proteinuria and his chronic kidney disease? And then, what is your diagnosis? And how does your diagnosis, in this case, how does our patient develop proteinuria? And finally, we give therapies to these people, but I will challenge all of us to ask, well, how are these actually working? And so those are the three areas that I'd like to focus on today. Let's start out with the first question. Why would we as healthcare providers care about someone like this who has chronic kidney disease? Well, firstly, the numbers vary, but a substantial part of our US population has different levels of kidney disease. Those at greatest risk are shown here: elderly, male, African Americans, and patients, of course, with diabetes. Now, importantly, if you look at this graph over here, these are years on the x-axis and numbers of patients. What we can see is that although the US population over this time period has only increased by about 37%, the number of patients with chronic kidney disease has increased ninefold. So we are seeing what we as nephrologists call an epidemic of chronic kidney disease. Recall, for the house staff, please, you don't need to have a creatinine that's super high before you call someone kidney disease. This guy has a creatinine of 1.5, and when we do his GFR, it's substantially depressed already. Well, what's charging this epidemic? You have many experts right here in nephrology and other fields looking at diabetes, looking at hypertension. Glomerular disease continues to be right up there, and then there's a number of other conditions like polycystic kidney disease. You should care about it for the following reasons. Shown on this slide are cardiovascular disease and all-cause mortality with declining kidney function. This is a seminal paper in the New England Journal about a decade ago, and this the x-axis, shows a declining GFR. And on the y-axis, in this case, is cardiovascular events, and on this case here is, well, you can read it better than I can, all-cause death. The takeaway from these two graphs is that as kidney function declines, cardiovascular disease is on the rise. And we would call this an independent risk factor and predictor for cardiovascular disease. Similarly with proteinuria, this is one of many studies. This is from a diabetic study, but the same is true for non-diabetic studies. And that is, on this axis here, we have 3 different levels of proteinuria, of increasing magnitude of proteinuria, and we have stroke, and we have cardiovascular disease events. The takeaway is that proteinuria by itself is an independent risk factor for cardiovascular disease and stroke. More proteinuria is worse. And so for the non-nephrologists in the audience, and for all of us, we care about the kidney, shown over here, that we've been taught historically of the traditional risk factors for cardiovascular disease. You know these as well as I. They're shown on the slide. I'm not going to repeat them. Hypertension, smoking, etc. But we really now have very important population-based studies showing that there are now some kidney-specific risk factors that push the patient towards cardiovascular disease. And proteinuria and chronic kidney disease are 2 independent risk factors. In fact, if we step back and say what happens to populations with chronic kidney disease, the bad news is that the majority of these patients actually don't even get to dialysis. That 80 or 85%, depending on the numbers you're reading, of patients with chronic kidney disease die on the way to dialysis, largely because of cardiovascular complications. So the first teaching point that I'd like to stress is, why do we care about it? We need to take this very seriously. We need to try and limit the progression of chronic kidney disease, and we need to try and limit and minimize the degree of proteinuria. So now that everybody's almost finished their lunch boxes, I'm sure that you all are now ready to be able to answer the next question. And so the question is, what is his kidney diagnosis? Recall the case that is highlighted above here. This patient has nephrotic range proteinuria with an elevated serum creatinine. If we put on our clinical hats for a moment, the teachings typically has been, these are syndromes that you can divide a patient like this into nephrotic or nephritic. Personally, I think these are a little arbitrary, but this is what the books tell us. And our patient really has 6 grams of protein, so we're already thinking he's in the nephrotic range proteinuria. His serum albumin is depressed and he has edema, so he likely is sitting in the nephrotic. Nephritic is more an inflammatory kidney injury. Typically is we have red cells and white cells in the urine, but that's not exclusive to that condition. So we're thinking he has nephrotic syndrome. And so what might be the causes? And is there hope for this gentleman? Is there ways that we might be able to cure him or help him or minimize his progression so that we'll minimize his risk of cardiovascular disease? Well, this is the favorite organ for at least nephrologists, and hopefully there are some nephroblasts in the audience here, because I showed you there's an epidemic of kidney disease, there are a lot of jobs, something that the house staff should seriously think about. So here's the kidney. And when we have nephrotic range proteinuria, the scene of the crime is almost certainly in the glomerulus. And so what we're going to focus on here now is this area of the kidney, the glomerulus. And I'm not, because of time, don't have time to talk about the tubular interstitium and the blood vessels, but certainly the glomerulus, typically we have about 1 million glomeruli in each kidney. And we're born with that number. There are a number of studies coming out that shown that there's a large variation in that, but essentially it's a fixed number when you're born. So if you're born premature, you're going to have likely fewer glomeruli than if you're born a normal gestation. So we're born with a fixed number of glomeruli. I've said to you already that this level of proteinuria almost certainly is a glomerular disease, so let's drill down a little further into understanding this a bit better. So if we look at this glomerulus from the top, and we now move into the kidney, what we see here is that we peel away this capsule, and underneath we see, hey, there are a bunch of cells over here. Now, of course, this has been adoberized, so we don't have green and purple cells normally. This is for the sake of the schema. But certainly, if we're looking, okay, that was an interesting fast forward through my talk. Any questions? Sorry. Let's try and find this again, shall we? Not sure what happened there. Let me try this again. Open with. Okay. Maybe I can ask the gentleman earlier who said...
No, there's no pointer. You have to use the stick.
Which I'm using the... on the mouse. I think that's what I was using, but maybe that's why I was a little twitchy. The pointer's here, but doesn't... Oh, this. Oh, this is really old school. Wow. Can I take this home? This will influence a few of my faculty. Okay, thanks. Yeah, okay. Sorry about that. Tools, presenter view. I think my mouse has become a bit twitchy over here in Miami. Okay, so what we have here, I'm just going to put this down over here. It reminds me of my days being in Catholic school with a cane. So I don't want to get PTSD right here in front of everybody. So anyway, I was one of those 10 years were terminated early. I was a bad guy. But anyway, that was then. So if we look down we move away the capsule, what we see are a bunch of cells over there in this one of these million glomeruli in each kidney. And if we drill down even further, we pull this thing out, you can see this is a ball of something. Now, if we strip away this outer layer of cells, what we see here are these beautiful vessels underneath. And glomeruli, the takeaway here is glomeruli is a very vascular bed comprising vessels. And if we cut through one of these glomeruli, what we see here on the top left is just an EM. And on the middle panel here is a schema that I've drawn for us to understand that the glomerulus has 4 different cell types in it. I'm a little scared here to actually touch my mouse, but what you can see, and I'm actually going to old school it just for this one here. What I want you to see here, these are blood vessels, right? And they're supported by these cells, the mesangial cells. And we'll speak about this a little later, but certainly we've got a lot of blood going through here, but we don't have proteinuria. So let's drill down a little bit further on that. And just to put some math to this, here's the importance of really appreciating what we need to keep us from limiting protein excretion. So if we take a normal cardiac output of 5 liters, mine actually just went up substantially now when I had that mistake over here with my laptop. Cardiac output goes to the kidney about 1 liter a minute. A blood flow is about 1,440 liters a day to these little glomeruli. They're sitting there getting bathed in this stuff. We have a normal serum albumin of 40 grams per liter. The takeaway is that there is a lot of albumin cruising through our glomeruli on a daily basis. Lots of it. But if you dipstick, hopefully the majority of us, we will have normal, no protein in the urine. All right? And so we filter a lot of blood, so something has to be super intact. Well, what is this? And we call this the glomerular filtration barrier. So what I'm doing over here is we're highlighting this little area here. Here's the blood vessel. Here's the urinary space. We're not seeing much in the urine. We're seeing nothing. So this filtration barrier has to be pretty much intact. And we can almost say with certainty our patient has 6 grams of protein. There's a problem with his glomerular filtration barrier. Let's look at this in a little bit more detail. This is a scanning EM, and here is a cartoon. And what I'd like you to take away is the glomerular filtration barrier has 3 layers. An innermost endothelium, a middle glomerular basement membrane, and an outer cell called the podocytes. And so many incorrectly think that it's the glomerular basement membrane that is the main resistor to protein loss. It's all 3. And we don't have time to get into all the details, but essentially, this is really twitchy here, sorry. So let's just look at this. This is from the outside now. These are the podocytes sitting, hugging the underlying capillaries. Here's a capillary. You can see a red blood cell sneaking around there. And there is the glomerular basement membrane between these. So these three layers, for a variety of reasons, are resistors to protein. They keep the protein in the blood vessels. And so, putting on a clinical hat for a moment, the way I think about proteinuria as a patient like this, and I'm not going to get into the weeds, but I just want to give you concepts to take away here, is that I think of someone, does he, in our case he, the patient, have a disease of the endothelium? And they're listed here, thrombotic microangiopathies, vasculitis, and so on. Does he have a disease of his glomerular basement membrane? Alport's, anti-GBM, thin membrane disease. Or does he have a disease that starts in the podocyte? And they are listed here. In a nephrologist, we've done a horrible job by calling our diseases descriptive names. Focal segmental glomerulosclerosis, minimal change, and membranous, just horrible words. But the takeaway is that these are diseases of the podocyte. So, next big teaching point, if you've got proteinuria, it's almost certainly a break in the glomerular filtration barrier that separates the blood space from the non-blood space. And just go through it sequentially, innermost endothelial cells, GBM, and podocytes. So what does our patient have? Well, he has the commonest lesion, and certainly commonest in African Americans, and that is that there is fewer than 50% of glomeruli affected, and there's a segment in the bottom left over there that is scarred. That's the segmental scar. And on EM shown on the left, the podocytes are in bad shape. So this is primarily a podocyte disease. He has lost that filtration, part of his filtration barrier, and through mechanisms that we don't have time to get into just yet, this leads to scarring. So that's our diagnosis, and I hope that you can appreciate why he has proteinuria. Podocytes are not doing their job. So what are we using currently for therapies? Sure you're putting on your thinking hats. And how do they actually work? How do these drugs work? That's an important question. And so when we think about it, putting on a nephrology hat, therapies for podocyte diseases such as this gentleman has, we can use a bunch of immune modulators, corticosteroids, cyclophosphamide, rituximab, and so on. And you have world experts in rituximab, Dr. Fornoni and others have looked at this in the podocyte, right here in your backyard. You're all familiar with the therapies that, quote, lower proteinuria, ACEs, ARBs, and so on. And we don't have time to get into it, but the takeaway here as well is that these drugs have systemic effects. We know that ACEs, for example, lower blood pressure. But they also have both the immune modulators and these RAS inhibitors and other drugs have direct actions on the podocyte. Let's just dwell a little bit on the podocyte for a minute or two, if you don't mind. This is a beautifully terminally differentiated cell, shown over here, that sits on the glomerular basement membrane and flaps around in the urinary space. But it has important properties, shown in the bottom part of the slide. It's a size and charge barrier to protein leaking. It maintains the integrity of the capillary loop. It's got a very active cytoskeleton. It makes and probably repairs the underlying GBM and makes matrix. And importantly, it makes important survival factors for its neighboring endothelial cell, VEGF just being one of them. And we know that these little slit diaphragms between these podocytes over here, looking at it from above, this is what they look like. And the size over here between these slits is just smaller than the size of albumin. And that's probably the size barrier, including the charge barrier. We now understand the proteins that make this very complex function. And ACEs and ARBs and corticosteroids and rituximab and other drugs do also work on some of those on some of these proteins. Okay, but we're still left with the question here: how does one halt or even improve his chronic kidney disease? And let me just take you briefly through the podocyte dilemma, and that is podocyte number. So following injury, cells detach or die, and you get a depletion in podocyte number. Now the bad news is that adult podocytes, for the most part, are unable to proliferate. So we're born with a fixed number. They really, like neurons, and perhaps cardiac myocytes, they cannot proliferate. And so the number continues to decline, and this is just a slide that I've taken all the literature, human, experimental, and so on. And what I'd like to show you here, this is the normal quota of podocytes, and this is decreasing podocyte number, decreasing podocyte number. You start getting, some of the gloms get affected as the podocyte number goes down and gets scarring, and then with time, even more gloms get scarred. So podocyte number really underlies scarring in the majority of podocyte glomerular diseases. It's really about the number. There's this tipping point that we can get into, but there's a tipping point with 30% of depletion, scarring is almost guaranteed. So if we put on our clinical hats, and there are a lot of white coats in the audience here, what we want to do clinically is say, hey, how can we get the podocyte number back up again? Because if we do that, we can hopefully even reverse scarring before it becomes too organized. And so that's the conundrum. I just told you that they don't proliferate. And so that leads to the whole story that certainly in order to increase podocyte number back to a point where scarring is not going to happen or is minimized, we need regeneration from another cell source, because podocytes themselves cannot proliferate. Has everybody got that before I transition? So we're relying on something else. So we're relying likely, and this has been shown, I don't have time to get into the studies, a podocyte number can be recovered. Not necessarily back to normal. We just wanted to get above that scarring threshold. ACEs, corticosteroids, there are a number of studies coming out showing that this indeed does happen. But how does this happen? Well, perhaps there's a role for progenitor cells. And I went to my favorite source to define progenitor cells, Wikipedia. And this is how Wikipedia, who we must believe sometimes, says what a progenitor cell is. You can all read it. I'll read it with you. It's an oligopotent cell that normally hangs out in a dormant tissue. Think glomerulus. But following injury to another cell, it says, hey, I have to become that cell. I want to take over the function. I'm going to morph and become that cell. And I'm going to now save the day. Right? That's sort of my version of what a progenitor cell is. So, are there candidates for adult podocytes in the glomerulus? So here's another view of a different area, of just looking at the glomerulus in a different cross-section. And we're asking, are there local or systemic or some other site stem progenitor cells that can replace lost podocytes? And there's at least two candidates that I'm going to talk to you about in a moment. And one is parietal epithelial cells, and the other are cells of renal lineage. So what about parietal epithelial cells? These are the cells that's sitting along Bowman's capsule. So here we have the capillary loop, here's the urinary space, and these characters sitting over here. They derive, during embryogenesis, from the same cell as the podocyte. So way back when, during embryogenesis, they come from the same cell. Podocyte goes his or her way, the parietal epithelial cell goes his or her way. And they've been ignored for years, literally ignored. But there's been this lovely resurgence in the last year or 5 years, actually, saying, well, maybe, if you go back to development, the fact that they came from the same cell, maybe the PECs, I'll just abbreviate them as PECs, parietal epithelial cells, serve this niche. And so there's several groups, including ours, that are looking at this. And so I'm going to move a little bit from sort of a clinical bent to a bit more of a researchy bent, and we'll try and tie this up at the end of here. So just hang tough here with the researchy part, because that's how we get ideas, and that's how we make change to patients' lives ultimately, in my opinion. So with our collaborators, we developed a mouse where if we give this mouse doxycycline using a certain promoter, we can make the parietal epithelial cells turn red. And so we can do that, and we can stain for podocytes, in this case with a protein that stains the podocytes green. And then we can come along and do a similar injury to our patient, and we can deplete podocyte number. And the takeaway here is, and I'm sorry that I'm walking around here like this, but the takeaway is that there are red cells that move in, and some of them become yellow. So red plus green equals yellow or brown. And so the takeaway is that cells move from outside inside. Some of them acquire a podocyte expression, and in the lower right panel is showing that there are a bunch of yellow cells with a different stain. And we've replicated this a number of ways. So this is one study suggesting that when podocytes are depleted, PECs can move in. And we can titrate the depletion in podocytes in our model. And once you get below a certain amount, then these characters are called in. So we thought, let's take this one step further. This is using immunostaining, but let's go with a genetic approach, a little bit more detailed. And so we've just made this mouse where, okay, forget everything I've said now, we're making a different mouse where we can make the parietal cells red, and every green cell here is driven by a podocyte promoter called nephrin. So in the same mouse, we can have a red parietal cell and a green podocyte. Everybody got that? So now we can trace and watch these characters where they go. And so what we'll do is, this is what it looks like just through another picture. And what we can see here is that PECs are sitting on the outside just like they're supposed to, and there's green fluorescent podocytes in the middle. Okay, let's just hope this works. Okay. Okay. This is what happens in disease. I hope you can see there's some red cells moving into the glomerulus once podocytes are depleted. And some of them become yellow. I don't know how well it projects over there. I'm too scared to almost look. And this is what happens when we cut through a glomerulus. I managed to switch it off by mistake, yeah? Oh, my goodness. Sorry, team. This is what happens when we cut through one of these gloms. We go right through with a confocal. You can see some yellow cells, I hope. So for a cell to turn yellow, it's meant the red cell has become the green cell, suggesting genetically that the parietal epithelial cell is transdifferentiating into a podocyte. All right? So the important clinical question is, and still at the experimental phase, because we can't make human podocytes green and so on, at least just yet. Don't think I'll get any volunteers for that one. But we've been asking, can we push this process forward? And the answer is yes. Experimentally, our group and others can. Corticosteroids can push this process. Your favorite RAS inhibitor can push this process. Retinoids. Another group has done miRNA inhibition. And Paula Romagnani and her group have used GSK inhibitors, pushing this process forward. So we can try and push parietal cells in the setting of podocyte depletion to hopefully regenerate podocytes. We don't really even care if they go back to 100%. We just want them to get above that threshold of scarring, because we want to halt or even reverse chronic kidney disease. Everyone tracking? That was a pun. Cell tracking, lineage tracking. In the last few years, we've also been interested in another cell type called cells of renin lineage. Now, clinicians in the audience know renin. We think about renin. We think about it as a hormone. We think about it as an enzyme that starts the whole RAS. It's the R in RAS. And it is that. And we know that these cells in the juxtaglomerulus, another beautiful kidney name, love this, next to the glomerulus, juxta, are these cells sitting over there normally that make renin. This is the major source of renin that we all have. However, our group and others around the same time showed that in the setting of podocyte depletion, these cells started making, not in every case, started expressing rather, podocyte proteins. And we thought these were antibodies, and we thought this was, you can imagine trying to get this through the reviewers, when suddenly you got a podocyte protein sitting in a cell of renal lineage. And anyway, the takeaway is that that really got us triggered. The good thing about a mouse is that there are 3 different renin genes. So we can manipulate, so far we've manipulated 2 of these genes to play around with cell fate mapping and deletion and chopping out and overexpressing specifically in the cells that derive renin lineage. I just want to say, because I don't have time to get into this, just think of the lineage. That's where they started. You don't have to be expressing renin to be of that origin. So we made a mouse. I'm running a little bit out of time here because I had my snafu there. We made a mouse where we want to cell fate map these. And Jeff in my lab made a mouse that we can report, in this case with GFP, we've done it with every kind of reporter you want, that localizes nicely to the renin, and these cells become yellow. We can then come along and injure the mouse, deplete podocytes, and see what happens to these cells of renin lineage. And the hypothesis was, can cells of renin lineage serve, are they plastic? Can they have other potential to become different cell types under certain conditions? I'm not suggesting this is happening every day, but when the podocytes are depleted. This is one picture from our study. And yes, the answer is, when we deplete podocyte, a bunch of these characters in some gloms go to the parietal epithelial cell, and different gloms that go into the actual glomerulus tuft itself. And so, this is just another picture showing the same thing. Maybe. That's a normal. And here is disease. And I hope you can see that the red cells of renin lineage move in to areas where the podocytes are fewer. So the question then comes up, well, so what? Are they actually expressing podocyte proteins? And this slide shows yes. I'm not going to get into the weeds, but the takeaway is that not all, but a subset of these cells that move into the glom, and typically in the areas devoid of podocytes, start to express, in this case, 4 different, what we call podocyte-specific proteins, suggesting that they are doing that. And we also have nice EMs that I couldn't find for my talk here, I'm sorry. Nice EMs showing that they take on ultrastructural features. Working with Janos Peripatodi, we said, well, let's fate map these even better real time. And we've generated a mouse where cells of renin lineage have now 4 different colors, so we can see if it's clonal or not. And this is live imaging. And what we're looking for over here is these cells moving in. You can't see them very nicely perhaps, but basically we can fate map live animals over time, and when we give the injury, a subset of these cells move in to the glom. And so from a clinical standpoint, we're asking ourselves, well, can we augment, can we encourage this process with some of the common drugs we're using and some other newer targets? I'll just tell you about some of our published work on some of the known drugs. When you give an ACE inhibitor next time, or an angiotensin receptor blocker next time, please think about it more broadly than just lowering blood pressure or lowering intraglomerular pressure. Because what we can show is that when we give in these settings, ACEs or ARBs, the number of these cells increase, their migration into the glomerulus increases in settings of podocyte depletion, and the percentage of them that actually transdifferentiate and start taking on a podocyte phenotype is also increased. We've done this with ACEs, we've done this with ARBs, we're looking at favorite drugs and other new target drugs as well. Trying to understand, is this a mechanism whereby we can regenerate the glomerulus and we can hopefully get the podocyte number up to a point where we can reverse any glomerular scarring, or certainly prevent it further. And just to take this one step further, we've made a mouse now where, again, using fate mapping, we can have a mouse that has red, on the top left there, red cells of renin lineage, We can induce that. We can give them tamoxifen and say, hey, every cell of renal lineage, please turn red. And they have constitutive podocytes are green through the nephrin promoter, through a different system, a flippo system. So we have these mice that have red cells of renal lineage and green podocytes. And asking genetically, do these characters, just to reinforce this, does this happen? And the answer is yes. Here is a baseline. This is what the animal looks like. And then we come along and lower the podocyte number. And I hope you can see, is it doing its thing there? Yeah. I hope you can see that red cells are starting to move in. I should have sped this up a little bit. Really early on. This is within 36 hours of podocyte depletion. I'll just give it one more turn over here. Podocytes move in to the glomerulus. And interestingly, it's always in areas, it seems, never say always, typically in areas where podocytes have been lost or decreased, as you can see over here. So these cells move in, and we can now use drugs, known and unknown, new therapies potentially, to try and push this process forward to see if this happens, which it clearly is. Just give me 1 second here. Okay. So the question now is, well, so what? You just got red cells that have moved in, or they're actually transdifferentiating into podocytes. And there's one glomerulus taking a confocal going right through the glom. And I hope you can see over here that there was red and there was green, and now there's a bunch of yellow in the middle of this glom, suggesting and hopefully convincing all of us that this is perhaps real, that using a genetic approach, that we can convince ourselves at least that cells of renal lineage may serve a progenitor niche for adult podocytes in stages of depletion. So let me just summarize what I've said so far. Almost finished, folks. Hang in there. Podocyte number is important. Podocytes are decreased in diabetes, in membranous, in focal sclerosis, all these diseases. And a low podocyte number underlies and leads to glomerular scarring. We want to increase that number. First, you want to prevent it getting worse. And secondly, because patients don't come in like that, they're not mice, they come in and their podocytes are already depleted. So we want to get the number back higher. We think that, and others do too, that there are probably way more sources than I'm showing you now, but this is our research, that there's a subpopulation of parietal epithelial cell progenitors, and there's a subpopulation of cells of renal lineage. Now, our job is to excite and get these cells doing what they're supposed to be doing, and hopefully move in and save the day. I'm not going to discuss aging, but I know there's an interest at the Stem Cell Institute over here about aging and regeneration. And we are funded to do aging studies, not because I'm aging, because I think it is important, and I am aging. My kids remind me all the time. And what we think, unfortunately, is a lot of these repair regenerative processes in the kidney are not working optimally in the aged kidney. And this may be one of the explanations why a patient who's 20 years of age and a patient who's 70 get the same disease. Maybe an explanation of why the 70-year-old is not doing as well as the 20-year-old. There are obviously a number of other comorbid conditions and so on. But this is an area that I think is of particular interest. I think it's important in transplantation as well, and an area of active study. And so finally, are there other model systems that we can use to better understand kidney regeneration? In the glomerulus at least. And so I'm going to end my talk here because I hope there's time, more than enough time for questions and answers, because that's really usually the most exciting part of any talk, or the most challenging. And that is, are there new model systems? And the NIH has put together a consortium of characters to try and better understand this. They've said, we as the National Institute of Health think kidney regeneration is absolutely critical, and we're putting our money where our mouth is. And so I'm going to just end over here, and then I'll take questions about a new model that we've developed called glomerulus on a chip. So what is glomerulus on a chip, and why do clinicians care about it? I am clinically active, I see people, but we need to be thinking of all new ways to do this. One of my BFFs, Ing Zeng, is shown over here. He's a bioengineer. These characters are incredibly smart, as you well know. And what we've done together with Ing is develop this glomerulus on a chip. And this is a nickel shown over here, just to give you a context of size. And the takeaway is that we have developed, and I'll show you a picture of this, a 3D system, where we're trying to recapitulate as best we can in a cell culture setting the glomerular filtration barrier. We want endothelial cells, we want a GBM, and we want podocytes. And then we want to play with the system and bring in stem cells, known and new ones, and iPSCs, inducible pluripotent cells, into our system to see in a model system, can these stem cells integrate, can they transdifferentiate, can iPSCs do this, can organoids do this? And so this is a system. So what we've done, we being Ing, and we being whoever we are, we got a number of different ways to do this. This is a matrix gel. This is looking from the top. The takeaway is that we can seed this with endothelial cells and put podos here. We can do it the other way around. And then Ing has made some little areas where we can pop in our cells of renal lineage or parietal cells or whatever your favorite potential cell is and see what happens. And so this is not the best picture I have, because my Dropbox at the hotel was a little sluggish, or I was, but something wasn't. So this is the best I have for now. But the takeaway is that shown over here, we've seeded endos and podos. And the good thing is that we have fluorescent endothelial cells, we have fluorescent podocytes, these are mice, we have fluorescent pecs, we've got fluorescent cells of renal lineage. So we're not really relying on markers. The takeaway is when you seed podocytes and endos, this is like Match.com or whatever the latest version is these days, where they seem to recognize one another, they send signals, podocytes move and endothelial cells, and they hug and they go crazy over here. As shown on the top right over here is a lot of yellow going on. Red cells hang out with green cells, they become yellow, and we can now flood the system with whatever our favorite is, including iPSCs and other cells. So this is a model that's ongoing, that needs to be validated, but I certainly am a believer in the days of doing monoculture in single cells in layers are likely seeing their days. Let me wrap up over here and take some questions. I discussed a 34-year-old gentleman who had clinical evidence of fluid overload. He had an elevated creatinine, so he's got chronic kidney disease. He's likely had this for some time. He probably had proteinuria going back to the age of 22 when somebody just dismissed it. As a nephrologist, we get this all the time. He just had a little bit of proteinuria. I don't know of anyone who's going to be told by an oncologist you have a little bit of cancer. So when you have a little bit of proteinuria, please take it seriously. His protein excretion was high. We did a CSI. We said the scene of the crime is at the glomerular filtration barrier. We dismissed endothelial cell diseases. We dismissed glomerular filtration, GBM, glomerular basement membrane diseases. The biopsy proved that this was a podocyte disease. So, and we understand that you're losing that barrier to protein excretion, where it's supposed to stay in the vessel, but that barrier is gone, so stuff starts to leak out. Our goal as clinicians is to do two things: halt the proteinuria and halt and hopefully reverse the CKD as well. Not only through nephrocentric view, but more importantly, or equally importantly, is that we want to limit cardiovascular complications. And that really is our goal. And that's what I was trying to say, that I think that the regeneration of the glomerulus is an important area of study. It's not the only area. You've got tremendous researchers working on this area right here. I suggest you please go and speak with them. These are some of the characters in the lab. But again, I'd like to thank the family for putting on this this lectureship, and I'm honored and excited to be here and deeply humbled. And I'd like to thank everyone for their attention. Thank you very much.
Thank you very much. Just a time for maybe a couple questions, and then Dr. Hare will make your presentation. The rate of progression through the different phases of chronic kidney disease although idealized in many drawings is predictable, clearly is different from individual to individual. Do we know whether it's the degree of insult that affects the progression to the chronic kidney disease, or are there endogenous regenerative factors that may protect people, some people longer than others?
Yeah, that's a very insightful question. And the quick answer is it's multifactorial. We know that there are genetic predispositions that make people more sensitive than others, African Americans being one as an example. Clearly, the repair systems are likely different in different folks. And the degree of injury has to be critical. But I would also say the time to diagnosis and treatment, because this is the lag time that we often as nephrologists get somebody who's been bumbling along for some time and their creatinine is elevated and we've missed the boat. So that's a great question. Probably a combination of injury, repair, and predisposition.
Very nice talk, thank you. I may have missed it, but do your models differentiate between new progenitors that are differentiating versus endogenous cells that have de-differentiated? For example, you may have mesangial cells that are suddenly expressing the progenitor markers.
Yeah, so the question is, do we differentiate between basically the cells that are sitting in the kidney that de-differentiate into a podocyte, for example?
Trying.
Yeah, versus an actual progenitor cell that's coming in. There was a time where the de-differentiation of podocytes were discussed. I think that the genetic tracing is telling us that this is probably not happening. And now that we're in a much more sophisticated area, we have not studied mesangial cells in these models. There isn't a specific reporter for mesangial cells at this time. We can use other fake ones like PDGF-beta receptor and so on. So I think at this time, the cell fate mapping studies tell us that it's likely, it's more consistent with another cell type becoming the cell, in this case the podocyte. That it's less likely that it's a native cell de-differentiating and taking on that phenotype. I think that's the difference with the cell fate mapping.
One more question.
So you seem to have numbers of different cells that can differentiate into podocytes, but they still can compensate for the loss. Why is that? It's in the heart that happens too.
So the question is a number of different cell types. Why can't they compensate for the loss? That is the million-dollar question, and thank you for that. Did you read my grant? I think, simplistically, there's a limited reserve. They got to get from one zip code to another. A number of them is not making it along the way. When they get to the new zip code, flying from Seattle to Miami, you got to transform into a local person, and that's tough. So I think that's a big, big challenge. So I'm less fixed on trying to get it back to normal. I think, to use your cardiology, and I'm not a cardiologist, but maybe use it as a poor example, you want to get the ejection fractures into a level that the patient can actually get out of the hospital, and not perfect. We podocyte types want to get the podocyte number to a level where the scarring either doesn't progress or even regress. And I think that would be a major feat. So yes, we want to push it and get back to 100%, but I'm not sure that's really needed. There's this tipping point where I think is a much more realistic goal. But how to do this, that's, I don't know.
Well, thank you very much. Today, we're especially pleased that the Lipson family is here, not just the first and not just the second, but the third generation as well. And we hope that Dr. Shankland, Dr. Fernoni, and others will have solved the problem so that your children don't necessarily need to see chronic kidney disease not yet cured. Dr. Hare.
Dr. Shankland, thank you for that really terrific lecture that I think laid out beautifully for us the state of the art in the field of kidney regeneration. As has been mentioned several times, this lecture is the third annual Arthur Lipson Lecture. We're very honored here at the university to have this lectureship as part of the Department of Medicine. And to commemorate today, I'd like to ask the Lipson family to come up and give us and help us give the plaque to Dr. Shankland. We're very honored to have Shelley Lipson here and several other members of the Lipson family. Shelley's son Eric is here, her daughter Heather and son-in-law Joe Schimmel, her granddaughter Sarah and her new fiance Lane, and Shelley's grandson Benjamin and his girlfriend Tammy. If you could all come up, that'd be terrific. I'd also like Dr. Schulman to join us. Thank you.
Yeah.
Yes.
Didn't realize I got a plaque.
Yeah.
Yeah.
In the middle.
Oh, in the middle.
Yeah.
This is a picture.
And Dr. Weiss, can you join us too?
Why don't you stand in front of me? Hi, how are you?
So, there you go. Thanks for coming.
Well, thank you. Yay. Okay. Why don't we hang on to this together? Yeah.
Everybody, 1, 2, 3.
Thank you, everybody.
Thank you. This is tremendous. Thank you. Wow. Yes. Didn't realize I got a plaque. Thank you. How are you? Nice to meet you. Likewise. Oh, I got a plaque. I can't say anything. I'm wired here, so let's not say anything we're going to regret later. I don't want to.
It really was terrific.
Clinical audience.
Yeah.
What the hell is that?
Yeah, you're done.